Good evening. Since you have heard all the previous lectures, now this is like a test for you, see how much you have learned. I'm just kidding. So, this is going to be a different type of lecture. It's not one subject. This deals with 30 different patients. Each one is a different disease entity. And every patient is 65 years and above. So there should be a handout it came in when they gave you the packets. There should be two handouts. One says the questions and answers, the other one questions, and the other one says answers and critics with references. So you need to have that thing because there's a lot of material to take home and read because I will not be able to cover all those details in this 20 minutes time. So I will try to do as many as we can. And, there are 30 questions. The first question is, which of the following agents increases bone mass and reduces fracture risk by stimulating the osteoblast activity and promoting the bone formation? Oral biphosphonates, estrogen, parathyroid hormone, selective estrogen receptor modulation, and zoledronic acid. Here, I am going to tell the answer and then discuss why. And for details, you need to refer to the handout with the answers and the critics and references. So here the answer is the human parathyroid hormone. So this is the number C here. There is only treatment that is approved by the FDA for treatment of osteoporosis in a different mechanism. There are two kinds of drugs that are used to treat osteoporosis. One is to increase the formation of bone by stimulating the osteoblastic activity. And then the other one is to increase the destruction of the bone by stimulating the osteoclastic activity. So this parathyroid hormone increases the activity of the osteoblasts. So answer is C. Number 2, a 70-year-old male smoker has a history of hypertension, dyslipidemia, diabetes, and non-valvular atrial fibrillation. Which of the following most increases his risk of stroke? As you get older, the risk factors change. As you get older, the atrial fibrillation becomes more causative risk factor for the stroke. So he's a 70-year-old man. The number assigned to atrial fibrillation is 3.3 versus the hypertension is 2.0 in some studies. That is in your handout. So in elderly patients, the atrial fibrillation is the most common cause as a risk of stroke. So the answer is D, the atrial fibrillation. Number 3, third question. Okay, number 3, a 72-year-old man comes to his office for evaluation because he has impaired fasting glucose levels. Fasting levels were between 110 and 120 on 3 occasions. He has well-controlled hypertension and his body mass index is 29.5. Diagnosing diabetes, the blood sugars between 110 to 125, as you know, is called the impaired fasting glucose, or pre-diabetes, between 110 to 125. 126 and above on 2 different occasions is diabetes. So here you have a patient with pre-diabetes or impaired fasting glucose on 3 different occasions. So which of the following is most likely to prevent development of type 2 diabetes mellitus in this patient? So one is to reduce the calorie intake and increase the physical activity to 150 minutes per week. That is a diet plus exercise. Second one is exercise plus metformin. C is metformin alone. And then D is reducing calorie intake, diet alone. They did some studies on this. There's a landmark study where they found out that the combination of diet and exercise reduces or prevents the development of diabetes. So if you have 100 patients, if you put them on the diet plus exercise and also the metformin, 50 of them you can prevent to develop into diabetes, and with the first one, the diet exercise, or the metformin alone is only 25 people you can prevent to develop diabetes. Question number 4. A 75-year-old woman calls the office to discuss a church-based screening program in which carotid arteries, abdominal aorta, and heel bone density are evaluated using ultrasonography. And she wonders whether it is worth the $85 charge. Which of the following is the most appropriate response? A, the screening is a bargain because each of these tests usually costs about $85, more than $85 at the local hospital. B, the screening may result in expensive or potentially risky procedures. C, if the sensitivity is high, the screening would be valuable. D, the screening should be done at the local hospital. See, all these questions, only one answer is correct. And one thing I forgot to mention is that in the critics, the references that you have in the handout, if you see SOE, A, B, C, D, that is a strength of evidence. A means, SOE means strong evidence in the literature. D means maybe. So some of them are SOEs and some are B's and C's. So here the question is not the cost. Basically, it is a community screening program in the church. They are screening they are doing the ultrasound of the carotid arteries, abdominal aorta, and the heel bone density. And the question is whether the test is necessary or not. It's not the question of cost, because some of these tests that we do may lead to unnecessary invasive procedures and do more harm than good. So we have to evaluate the effectiveness of these procedures, whether medical necessity of these procedures. And the answers here are screening is a bargain because each of these tests usually costs more than $85 at the local hospital. Well, the cost is not the question, whether the patient needs the test or not. And second is the right answer, B, the screening may result in expensive or potentially risky procedures. See here, they are screening the carotid arteries. Screening is not advised by the United States Preventive Task Force. Screening is not advised for asymptomatic carotid stenosis, first of all. Then they don't need the ultrasound. And second thing is abdominal aorta. The abdominal aorta is good if you is a woman actually. So that is why they specifically put it as a woman. So the abdominal aortic screening is recommended in men between 65 to 75 years of age with the history of smoking. So if the idea is that if the aneurysm is more than 5.5 centimeters, surgical intervention will be beneficial. So this is a woman, so this is not a necessary test. And also the ultrasound of the heel for the osteoporosis is a useless test. The osteoporosis is diagnosed using the DEXA scan. That's minus 2.5. I think Dr. Srinivas Reddy was telling in his first lecture. So minus 2.5 standard deviation is osteoporosis, and minus 1 to minus 2.5 in between is osteopenia. So here the correct answer is the screening may result in expensive or potentially risky procedures. Next question, number 5. A 78-year-old woman is admitted to a short-term rehabilitation facility after an elective replacement of her right hip. Surgery was uneventful and she began in-hospital rehabilitation shortly thereafter. On examination by the rehabilitation physician, there is a 6 by 4 centimeters area of non-blanching erythema on the patient's left buttock. It is boggy, purple and painful. Skin is intact. Which of the following describes these findings? Pressure source, stage 1 or stage 4, or deep tissue injury, partial thickness ulcer, or unstageable pressure ulcer. The pressure ulcer or decubitus ulcer, in 2007, they revised the classification. Before, there used to be 4 stages. Stage 1 is a non-blanchable erythema. Stage 2, partial skin damage. The stage 3 is full thickness skin involvement, and stage 4 is subcutaneous and deeper tissues. In 2007, they added 2 more new entities called, one is called the deep tissue injury. This is one of the common situations in the office type of practice. Which of the following should you recommend? We have 86-year-old man. Would you recommend a colon cancer screening by colonoscopy or a fecal DNA test, flexible sigmoidoscopy, air contrast bare minima, or no testing? Well, the correct answer is E, because he's 86-year-old. Again, this United States, the Preventive Task Force has recommended that you screen the colon cancer between 50 and 75 years of age. And unless somebody has a family history of colon cancer, then you start 10 years below the youngest age the family member had, 50 to 75 years of age. And also they do not recommend routine screening for colon cancer between 75 to 85 years of age, because of the other coexisting morbid conditions at that age. And also the detection of an adenoma, it takes a longer time to become a cancer. So even if you detect it, usually at that age you will have other medical problems. So that's why, and above 85 is definitely not recommended. So that is a question about the colon cancer screening. Next is item number 7. I know I may not be able to finish all the 30 questions. We will do at least half of them, and remaining half you need to take that handout home and read. Question number 7. 69-year-old man comes to the office to establish care. His wife is being treated for osteoporosis, and she wants to know whether her husband should also undergo a screening assessment. Which of the following is the strongest risk factor for osteoporosis in men? Androgen deprivation therapy, low dietary intake of vitamin D, respiratory disease, and thyroid replacement therapy, and type 2 diabetes. Here the answer is androgen deprivation therapy. In men, there is only few things that, the woman osteoporosis is more common in women. However, in men, androgen deprivation therapy, whether medical or surgical for prostate cancer, with orchiectomy and those kind of things, that's one of the predisposing conditions in men to develop osteoporosis. And other being the older you become and the thinner you are, you have a better chance of developing osteoporosis. So the androgen replacement therapy is the right answer for that. Which of the following is most likely cause of new onset vaginal bleeding in a 70-year-old woman? The most common cause of a vaginal bleeding in the postmenopausal woman is vaginal atrophy. And the second is the polyp. Next. A 74-year-old man undergoes initial screening colonoscopy. He is asymptomatic and has no family history of colon cancer. Fecal occult blood test is negative. A 3 centimeters adenomatous polyp without ATPI is removed via polypectomy. The colonoscopy is otherwise normal. When should the colonoscopy be repeated? 6 months, 1 year, 2 years, 3 years, 5 years. So 74-year-old man, look at the size of the polyp, 3 centimeters is adenomatous polyp. Should be repeated after 3 years. So there are some indications for repeat colonoscopy. For example, if there is more than 1 centimeter in size polyp, that's number 1. And number 2, there's more than 3 polyps that you detect, or a high degree of dysplasia. And those are some other things that you do. 3 years repeat colonoscopy. And if it is just a hyperplastic polyp, then it is 10 years. And in between there are different varieties. So the correct answer is number 3 years. It's number D. 72-year-old man is seen for preoperative assessment in anticipation of prostate biopsy as asymptomatic aortic stenosis with a stable 3 to 6 holosystolic murmur and type 2 diabetes mellitus. Controlled by diet. He is allergic to penicillin. He has taken cephalexin or clindamycin for dental procedures in the past without difficulty. Which of the following is most appropriate recommendation regarding endocarditis prophylaxis for the biopsy? No prophylaxis, oral cephalexin, IV cefazolin, oral cephalexin plus clindamycin, IV cefazolin plus IV clindamycin. See, in 2007, American Heart Association has revised their recommendations for endocarditis prophylaxis. GA and GU procedures do not require prophylaxis. So here the answer is no prophylaxis. Okay, next is 11. A 83-year-old woman comes to the office because she has shortness of breath when she exercises and general fatigue and weakness. She reports no abdominal pain, change in bowel function, rectal bleeding, passage of black feces or chest pain. Examination normally except for stool which is positive for occult blood. Hemoglobin 8.9, MCV 75, ferritin 10. Upon intestinal endoscopy and colonoscopy are normal, upper endoscopy and colonoscopy are normal, and no potential bleeding source is identified. Which of the following studies should be done next? Angiography, CT enteroclysis, small bowel barium radiography, double balloon enteroscopy, and capsule endoscopy. Because since we have heard a lot of procedures from the previous lecture, you have to decide one which you are going to do. In a case like this, there is, even if doing the upper endoscopy and lower endoscopy, there's about 5% of cases where you cannot diagnose the condition where it is causing the bleeding, being the small intestine most likely. Then there are 2 studies that Dr. Reddy has just shown. One is a double balloon enteroscopy or capsule endoscopy. You have seen those pictures, both of them there recently and last lecture. And double balloon, both of them can be complementary to each other. And then capsule endoscopy, you can visualize the whole small intestine, as you have seen in the video there. So here the correct answer is the capsule endoscopy, although both can be done, the double balloon enteroscopy and the capsule endoscopy, to visualize the small bowel. Next question 12. A 65-year-old woman comes to the office because she has facial rash with stinging, burning and tender pimples. The rash began recently and is causing increasing redness. On examination, there is erythema underlying central facial papules and pustules with telangiectasias. The distribution is over the central region of her face and includes her cheeks and chin. Which of the following is the most appropriate initial approach? Okay, first you need to diagnose the condition before you start the treatment. This patient has what is called rosacea, like the telangiectasia of the blood vessels in the face. Yes, if he's so rosacea is very important. Sometimes it can cause disfigurement and loss of vision. So you need to diagnose it, and then it is a stage 3 because of there is some pustules and papules involved. So stage 3 is treated with antibiotics, tetracycline, and earlier stages can be treated with the metronidazole cream. That is a rosacea. 75-year-old woman, case number 13. 75-year-old woman comes to the office for follow-up evaluation of an ischemic stroke 2 months earlier. History includes hypertension and COPD. She had a TIA 2 years ago, after which she has taken aspirin 81 milligrams per day. Since the ischemic stroke 2 months ago, she also has been taking clopidogrel 75 milligrams per day. Other medications are lisinopril, salmeterol inhaler, and tiotropium, 1 capsule inhaled daily. An examination BP is 135 or 80, and which is similar to readings before her stroke. Total cholesterol 250, LDL 180, HDL 50, triglycerides is 80. Which of the following should be done next? So here you have a case with aspirin failure. This patient had a stroke 2 years ago. Then he was started on aspirin. Then she got another one. She had a TIA 2 years ago. Now 2 months back she had another stroke, even though she was on aspirin. So that is an example of an aspirin failure for the secondary prevention of stroke. So here you got options. Number 1, discontinue aspirin. Number 2, discontinue clopidogrel. Increase aspirin to 325 milligrams per day. Discontinue aspirin and clopidogrel and start warfarin. Next, start lovastatin, and next one start warfarin is the next one. So one of them should be correct. Discontinue aspirin is the right answer. I will tell why. Because this patient, the combination of aspirin and clopidogrel, the second choice is wrong, because this patient doesn't have any coronary artery disease or any previous cardiac problem. So only the aspirin is the one that is indicated. And discontinue aspirin and clopidogrel and start warfarin. There's no need for the warfarin here, because it's not a stroke related to the atrial fibrillation. It's ischemic stroke. So aspirin as well will do the job. But the dosage that the patient is on, increasing the dosage from 81 to 350 or 325 will not prevent further strokes. There is some references in the handout. Please refer to that. So you need to discontinue aspirin and continue the clopidogrel. There are 3 choices you can use for the secondary prevention of stroke. Number 1, aspirin alone. Number 2, clopidogrel alone. Number 3, aspirin and persantin combination. So the correct answer is discontinue aspirin and continue the other one, the clopidogrel.
Okay, time is over.
Yeah.
Time is over.
Okay. Okay, one last one. 82-year-old man who lives in nursing facility is evaluated because he has a facial rash. Has been taking ciprofloxacin therapy for 5 days for a urinary tract infection. History includes Parkinson's disease and dementia. An examination, the rash comprises mild erythematous plaques with fine scales along the frontal line of the scalp, as well as moderate erythema with increased scales along the nasolabial folds bilaterally. Which of the following would be effective as an initial step in managing this patient's rash? This patient has a skin condition called seborrheic dermatitis, which is treated with a combination of ketoconazole and the steroid. The correct answer is E.
Time is over, sir.
So, yeah, I'm done. And also the handout has, please take it home and read the rest of the questions by yourself. Thank you.
Thank you very much, sir, for your nice presentation on recent advances in geriatric medicine.
Question?
Okay, please. Only one question, please, as we are lacking short of time.
Which one? Which medicine you're talking about, sir? Dose?
In all these medicines which you are going to give, which have narrow margin of safety particularly, are they standardized in geriatric patients before you prescribe, or are you giving targeted and empathy?
Okay, like for example, Coumadin you give for atrial fibrillation and DVT, those things. In elderly people usually start at about 5 milligrams per day, and you get the INR peak between 2 to 3 between 4.
Change after the age of 65 years, the hemodynamics, like the blood circulation, and everything changes.
Yes.
Function, everything.
Yes.
Then the doses have to be standardized before you are actually going to prescribe the narrow margin safety drug.
That's why you need to monitor those levels.
Is it being done or empirically, arbitrarily are you creating?
Well, start low and go slow. In elderly people, the kidney, depending upon the drug, some are excreted to the liver, some through the kidney. So, better to start with the lowest dose possible. The dose of the medications you cannot generalize because there are so many drugs with so many kinds of metabolisms. You have to depend upon the drug and the patient. Somebody is kidney failure, for example, of course the thing.
This has to be developed. Standardization has to be developed.
There are some formulas to calculate the dosage in elderly people, depending upon the creatinine level and the liver functions of the patient has any.
It should not be arbitrarily done in an elderly person. It should be done individualized about that. The evidence has not been developed.
Okay.
So because you cannot generalize those, because there are so many drugs, each drug is different, and you cannot generalize and say, you have to give only the half the dose and like that thing. It depends upon the drug and the underlying condition of the patient.
Okay, sir. Thank you very much, sir.
Kidney,
The data should be developed
ఆయన వదులుతలేడు
depending upon the clearances of the drug in the body. And different doses.
yeah, that's why you have to use that PDR, what we call as, that is the gold standard to refer the physician desk reference thing. That has got all the side effects, the dosage reductions, and each dose is different. Well, they
Okay.
got the evidence to prove their recommendations, I guess, FDA. Thank you.
Right, sir. Thank you very much, sir, for your excellent presentation. I request to our guest speaker, Dr. Mohan Mallam. And present a bouquet by Dr. Sudarshan Reddy.